when we look into the future, I'm really excited about what's happening in colorectal cancer. We see comprehensive molecular profiling really become commonplace in the management of patients. And at my institution, we actually profile patients with whole exon sequencing, whole transcriptome sequencing upfront, not to miss patients with NTRK fusions, for instance, or other targetable mutations or alterations, which is really exciting for these individual low-frequency patients. Then there are new combinations, which I find quite interesting. Combination of TAS-102 plus bevacizumab was just published in Lancet Oncology, a randomized comparison from Denmark, showing that the addition of bevacizumab to TAS-102 improves survival and progression-free survival in what I believe a clinically relevant way. And this is not a lot of toxicity. And it makes sense because we know that bevacizumab adds activity to being added to fluoropyrimidines, which TAS-102 trifluoridine is, which is a fluorothymidine, so fluoropyrimidine. Then I think the most interesting combination, though, emerged at ASCO 2019 in a combination of regorafenib plus nivolumab. Regorafenib as a multi-kinase inhibitor is known and has been known to modulate immune responses, modulate the activation of macrophages, for instance, modulate the activity of checkpoint inhibitors like nivolumab. This ties into something we have seen in other cancers like endometrial cancer, where the combination of lenvatinib, which is a multi-kinase inhibitor with an anti-VEGF component similar to regorafenib, plus pembrolizumab has shown to be effective and is actually FDA approved now. So the combination of regorafenib and nivolumab showed very interesting activity, in particular in MSS tumors which we normally do not consider immunogenic at all. And to highlight this, in this 25-patient study from Japan, which is of course small and we need to have more validated, more larger information about these patients, these 25 patients, had a 36% response rate in MSS tumors. Very interesting, because the regorafenib's response rate in a later line setting is perhaps 1%. Nivolumab's response rate in a later line setting in MSS tumors is 0. So 0 plus 1 equals 36. So there seems to be some synergism going on. Also interesting that the dose of regorafenib that was needed to mediate this immune activation was only 80 milligrams. And so half of the package insert dose of 160 milligrams per day. So there seems to be something going on in terms of biologic synergism, augmentation of immune response. And if these data hold up, that's going to be a game changer, not just for colorectal cancer, but for a lot of tumors. Otherwise, I think that I do believe that augmented immune therapy, enhanced immune response, is really the holy grail of where we'd like to go in the management of colorectal cancer. We have our subset of patients, 4 to 5% of patients with metastatic colorectal cancer carved out that respond beautifully to immune checkpoint inhibitors, the MSI-high, mismatch repair deficient tumors. But the vast majority of patients right now are not candidates for immunotherapy. We need to change that, and hopefully with the rational combinations, with combination of immune checkpoint inhibitors or plus minus multi-kinase inhibitors, I think we're on the good way for that.